Good morning and welcome to today's webinar by SAHPRA, titled A Conversation on the Dangers and Abuse of Codeine-Containing Medicines. The South African Health Products Authority has detected a burgeoning abuse of codeine-containing medicines, especially amongst the youth. There's also concern about the unethical conduct of pharmacies and pharmacists in this regard. As it is Youth Month, SAHPRA decided to host this webinar to raise awareness on the dangers of codeine and its abuse. Codeine is a classified opioid. Opioids are narcotics with known potential for dependence. Codeine is administered in liquid form or solid form, tablets or capsules, either alone or in combination with other active pharmaceutical ingredients. When used under the direction of a health professional, codeine-containing combination medicines are a relatively safe way to treat minor pain or suppress non-productive coughs. Codeine can also cause euphoric effects, which reinforce continued use. Codeine therefore poses a risk for developing tolerance and eventual dependence. SAHPRA is aware of the illicit sales of codeine-containing syrups through illicit and illicit facilities, and is working on means to prevent, detect, respond appropriately, working with relevant stakeholders, including law enforcement agencies. SAHPRA is also committed to strengthening medical regulations in the country and in the region through the adoption of regulatory harmonization policies, including the African Union Model Law for medical products regulations and strengthening cross-border surveillance systems. From this webinar, we expect that we will be able to create awareness on the dangers of misuse and abuse of codeine-containing medicines. We also hope to create awareness on illicit dispersing of codeine-containing medicines, and also create awareness on the roles of the various bodies in curbing this unethical and dangerous practice, and awareness of law enforcement in ensuring that South Africans are safe in this context, and collaboration in fighting the misuse of codeine abuse. This webinar comprises of speakers from different sectors and stakeholders that are pertinent in terms of ensuring that codeine is not misused. And as such, I'll start by introducing myself. My name is Sibusiso Hlejwago. I'm the Director for External Affairs at PATH, and I'm also a member of SATAG. And then also going to be part or amongst the speakers for this webinar, we've got Dr. Boitumelo Semete, who is the CEO of SAHPRA. We've got Mohadi Fafudi, the Manager, Regulatory Compliance at SAHPRA. We've got Nhlamulo Nkanyane, the Head of Professional Conduct at the South African Pharmacy Council. And then we've got Dr. Mariette Eckstein, the Professional Development Officer at the Pharmaceutical Society for South Africa. We also have Colonel Zakaria Setwape, South African Narcotics Enforcement Bureau. We also have lastly Mr. Koketso Mokubane, Health and Community Linkage Officer for the South African Network of People Who Use Drugs. So again, welcome to this webinar. And if you have any questions, we will encourage you to put them on the chat. And at the end of the session, we'll make sure that we respond to those questions. Also, please make sure that if you using social media and you want to create visibility on these discussions, use the hashtag SAHPRA Codeine Webinar 2022. We'll post the hashtag on the chat as well, so that you can be able to use it in terms of social media. And then with that said, I'll take the opportunity to welcome Dr. Boitumelo, who is going to be our first speaker for the day. Dr. Boitumelo.
Thank you very much, Sibusiso. And mine will be brief because I do think that we have an esteemed panel of colleagues who work with us as regulators in the space of codeine regulatory oversight. This is a matter that not only concerns us as South Africans, but also across the world. What we have observed is that various countries are regulating this product. And as Busiso said, this is a product that, because it's an opioid, it does pose a risk for dependency. And we have seen this risk manifest in the country, wherein we have a number of our youth that are becoming addicted to this product that's available either in cough syrups, etc. And so we've spent a number of months looking at how to efficiently regulate this product to ensure that those who do require it for the medical conditions that they are experiencing, as Busiso said, it's used for the treatment of pain, exacerbated coughs, etc. We want to ensure that those who do need to access it can access it, but also those who are not to access it, that we create mechanisms that they do not, because we are very concerned about this dependency and abuse that we're seeing for this product. We've engaged with manufacturers and suppliers of this product, and collectively are working together to ensure the safety of our population. And so today we have brought, as Busiso has said, a number of stakeholders, and they will share with you in terms of all our respective roles, what it is that we have in place, but also create awareness really around the dangers of abusing this product and some of the risks that it presents to particularly our youth, wherein we're seeing this increase in the abuse of the product. And so we hope that as we engage with yourself, as you will be also asking us questions, we start a journey really collectively as citizens, as well as regulators and various stakeholders in the country to ensure the safety of our public. And with that, Busiso, I'd like to close here and hand over to, I think it's Stephanie that's coming up next.
Thank you very much, CEO, and thank you very much, Busiso. Good morning to everyone. My name is Mokgadi Daphne Fafudi. I am the manager in Regulatory Compliance Unit of SAHPRA. And ladies and gentlemen, this is a topic that is close to my heart and my team. And I would just like to, because this is a youth month, again, as the CEO has said, we saw that it would be necessary to just engage in this topic that we really share close. We really, it affects us very closely as the regulator. And I manage the Regulatory Compliance Unit. The Regulatory Compliance Unit of SAHPRA is also responsible for ensuring that all narcotic substances in the country are regulated in accordance and our public is safe in getting those. So as you know, that SAHPRA regulates in terms of licensing, registering of medicines or authorizing them in terms of Section 21, and also monitoring that compliance therefore of those substances in terms of quality, safety, and efficacy is upheld. And my unit is very key in ensuring that we uphold that responsibility of monitoring compliance in the market. So ladies and gentlemen, if you look at the products that are mainly concerning in this regard when we speak about our youth and access, these codeine-containing substances are the ones that are recurring in terms of consents. So without just targeting any brands, but these are the brands that are already making loud noise, which when we are monitoring, those are the ones that we mainly come across. And as the CEO has said, in terms of monitoring compliance and also engaging, we have been doing this throughout the supply chain because as we know, codeine is an opioid narcotic. And in terms of opioids and narcotic substances, these are controlled internationally. So South Africa is a member to the United Nations, and there is treaties that regulate how we function. and narcotic substances are controlled in terms of the 3 conventions of the UN, the UN Convention on Narcotic Substances, the UN Convention on Psychotropic Substances, and the UN Convention on Prohibition of Illicit Trade in Narcotics and Psychotropic Substances. So every member state needs to put in regulations in place that will ensure that there is compliance with priority of enabling access to healthcare when required for treating diseases, and at the same time preventing access to illicit market, and also balancing with harm, ensuring that there is harm reduction in this regard when there is a use of these substances. So, and as you know, the South African Health Product Regulatory Authority in its frameworks also ensures that there is licensing of all establishments in terms of the Medicines and Related Substances Act. And then also we control this through scheduling. And also in addition to scheduling, we will register those products or authorize them in terms of Section 21. And then also in addition, these substances, because they're internationally controlled, we control them in the form of issuing permits for any import, any export, for any manufacturing of these batches. So South Africa today ranks among many countries that are hit by a plague of addiction, substance abuse. So due to misuse of the substance, access where it shouldn't be accessible, and not for medical purpose, but for recreational purpose. So in terms of this, colleagues and ladies and gentlemen, we see the glamorization by the society in terms of the codeine containing medicines. This is cough mixtures, this is your pain medicines, but mainly targeting the youth. There are songs that are sung relating to codeine. We hear that in clubs, these substances are easily available, and these are medicines which are mixed with drinks. And we see also on social media platforms, people showing this off. And the danger of it is that with this, when they are issued rationally in a pharmacy or in an establishment that is allowed, there are dosage instructions where a person knows that they take 2 medicine measures 3 times a day or as directed. However, in these platforms where we see this abuse, you see full bottles, people drinking full bottles or mixing full bottles with alcohol. And we know the danger of mixing alcohol and opioids. So this rather becomes even more concerning, because when you look at the youth, who is our future, where are we seeing the future? Because bronchlear with codeine, as I indicated that we've got scheduling as a measure of control, we have got these substances scheduled under either Schedule 1, Schedule 2 and above. And we know that codeine on its own is under Schedule 6, which is our highest schedule, which we control. So, but in terms of combination products, we therefore make it lower where it's accessible either in Schedule 1 or 2. However, should we review that? Because this is accessible in a pharmacy where pharmacy-initiated therapy can make this available for the purpose of control of minor pain or even cough in terms of different products like still pain, or so in terms of bronchlear with codeine, or even with Benylin with codeine. This can be this will be used for those indications. And when a pharmacist is involved or pharmacy support personnel that is allowed to do that, that will be done in accordance with the provisions. So that's how accessible it should be, or with a doctor's prescription. So now the teenagers are mixing it with alcohol and therefore leading it to serious health effects such as tolerance, dependency, and addiction. So ladies and gentlemen, I just want to take us through the pharmaceutical supply chain, where the pharmaceutical supply chain We know that in South Africa, we have got the manufacturers of the API, which is, we've got a sole one locally. And then in addition to that, we have got the manufacturers of the finished products. From manufacturers of the finished products, therefore, we've got our wholesalers. From our wholesalers, ladies and gentlemen, then we have got supply to the pharmacies, whether it's hospital, community pharmacy, or the facilities that are enabled in terms of the DG to supply that, like the dispensing doctors and clinics. So how have we been as the regulator engaging this? So all these products, for them to be available, we have to report in terms of consumption on an annual basis to the UN, International Narcotics Control Board, where we list the estimates, for example, to say that in terms of codeine, this is how much South Africa will use codeine in this year. And we have to substantiate, and then we also have to give data on the previous consumption as to, in terms of API manufacturing, how does it, how do we get that, how much, how is it consumed, and where does it go to in terms of manufacturing of finished products? Do we export, do we import, do we manufacture locally? And then in terms of that as well, we report, and then throughout the supply chain to also indicate where does it go to, where does the bulk of it go to, and where we are demonstrating that access for this is mainly for medical consumption, for treating unmet diseases. And therefore, as a pharmaceutical industry, the supply chain of pharmacies will understand and remember that we always require quarterly consumption data, and we'll also monitor in terms of ongoing visit to these pharmacies to ensure that there is proper use of these substances. And ladies and gentlemen, what we have started engaging, because we need to review whether South Africa is, in terms of the scheduling status, are we lenient in making this accessible through pharmacist-initiated therapy, or should we look at this being only accessible through a doctor's prescription? Worldwide, we would remember that a number of countries, most of the countries are having these substances accessible only through a prescription. So in South Africa, the question is our pharmacists not able to manage? Do pharmacists believe that they are not good enough in making sure that this is only accessible for patients who need them? And through our post-market surveillance programs, we have also noted that a lot of pharmacies, you find that there are no proper pharmacy personnel, and in some instances, these substances are sold in boxes, whereas we are expecting that this be sold per patient as per indication. And when these are sold in boxes, the question becomes, why are they sold in boxes? Is there a problem? Should we review how we are enabling access for this, or can we work together to identify those problematic areas that are enabling this access, which should not be accessible to those who don't need these medicines? So with that, I'm just asking, because I know we've got a lot of pharmacists on these platforms, to say that remember the youth is our future, and remember your professional obligations. This is to the healthcare professionals who are taking care of the safety of the public. So we as the regulator, as I indicated, that we have got international obligations that we need to uphold, and also our key mandate is to ensure that the medicines that are available in the country are safe for those that are meant to use, and they will do what they are meant to do, and they will be of quality. So ladies and gentlemen, we've got the United Nations Office on Drug and Crime, which is also concerned about the scourge of codeine substance abuse. So we need to ensure that in enabling access, we take our responsibilities seriously because of the repercussions of not providing our professional mandate as we should. Therefore, this is one of the means to collaborate and cooperate with you to ensure patient safety and ensure that the future of our country will be bright. Because, ladies and gentlemen, what are we without our youth? Where is the future without our youth? It is doomed. So therefore, manufacturers, as we are engaging with you, and the good thing that we are seeing in the past 6 months is that the positive interactions that we are having with the manufacturers, that we are having with the wholesalers and other colleagues throughout the supply chain are slowly beginning to yield results, but the results are not good enough. So because from the end user side, there's still a lot of education that is required and a lot of corporate social responsibility initiatives that we together need to engage in to make sure that the future of South Africa and that of the world is it's brighter. And in terms of professionals, colleagues, we need your input in ensuring that our legal mandates will be responding to the needs of the country and in terms of access to health, but at the same time, the safety of the public. And let us work together in terms of strengthening education and awareness, especially at schools or wherever we can. If the pharmacists are not the ones that are enabling this, then who is? Because it comes from a pharmacy, whether it's a manufacturer, this is a pharmacy, whether it's a wholesale, this is a pharmacy, whether it's a retail pharmacy or a hospital. It's unlikely with the hospital pharmacies because we have reviewed data. The community or retail pharmacies have shown to be the most problematic and concerning ones. Therefore, we need to zoom into how do we curb, how do we prevent, how do we detect, and how do we respond to this wicked problem. And ladies and gentlemen, so as you have heard that there is a person that is living with the experience who is going to be part of this. So we are urging that from this, can we work together just to ensure that we will improve the livelihood of our adolescents, and so that we can have a better nation which will be healthy, because this has got cognitive impairment and these are still in their developmental stage. So we don't need them to be having poor concentration, dropping in performance and feeling drowsy when they should be actually at their peak. With that, I just want to thank you very much. Back to you, Sibusiso.
Right. Thank you so much, Mohadi, for the information on the use, misuse, abuse, and trends on Codain, and also the strong message on what the youth, what the country is doing to ensure that the youth is protected. Indeed, it is Youth Month, and you've rightly said that the youth is our future, and all professionals have got the responsibility to ensure that our people are safe. And then with that, we will move on to Ntlamulo, who is the head professional conduct at the South African Pharmacy Council. She'll speak to the conduct of, she'll speak to the code of conduct for pharmacies and pharmacists and pharmacies. Over to you, Ntlamulo.
Thank you, Sibusiso, but I'm he, not she. Thank you very much. My name is Ntlamulo Nkanyane from the Southern Pharmacy Council. If someone can share my slides, please.
We're working on it.
Thank you very much. For the sake of time, so in slide 1, you'll note that we talk about the establishment of Pharmacy Council. Council is established in terms of Section 2 of the Pharmacy Act, which regulate pharmacy personnel and premises which are pharmacies. So one of our objects is to promote public health to the population, and also to regulate the practice, the education, the professional development, which is CPD, and the pre-reg. And in terms of our department, we investigate complaints of unprofessional conduct. So some of the things which Daphne has touched on is in terms of the code of ethics, where we have some of the code of ethics which deals with this problem of codeine or misuse or abuse. So we have Rule 1 and Rule 23. Rule 1, which deals with the failure of pharmacists to advise the patient when they are dispensing this medication. If you can go to the next slide, please. And we also have Rule 23, which directly deal with the abuse, dispensing in a manner which may be calculated as a misuse or abuse of medication, where Daphne has also touched to say, you'll see pharmacists dispensing in high quantities. Instead of dispensing per patient, they'll be dispensing in boxes. If you can move the slides, please, for me. Then we also have Rule 1.1, which is failure to take into account the best interest of the patient. And in most cases here, it will be the family members that now are complaining to pharmacy council to say this pharmacy will have reported to them to say they must not longer dispense to this person, but they are continuing dispensing to this person. So we do charge people in respect of that. And we also use the Medicines Act around the recording of Schedule 1 and 2 in terms of Regulation 35 of the regulations which are published under the Medicines Act, which requires pharmacists to record every sale or purchase of Schedule 1 and 2s, as we know that the codeines or the bronchial pain.
I think your colleague is sharing the slides. If she can either send the slides to us or move the slides so that they align to the slides that you are.
Okay. No, thank you very much, Moses. So when I go to the third slide of my presentation, that will be dealing with the transgressions. How do we deal with these transgressions at cancer? As you know that we are established by the Pharmacy Act, there are things that we can do, there are things that we cannot do. Unfortunately, for the premises that are not registered with us, there's nothing that we can do, but there is something that we can do because we do refer these matters to our colleagues at SAPRA for them to investigate, and they will do so with the law enforcement. So we also have a pharmaceutical task team where you will notice that there is a high number of hijackings of trucks. For sure, maybe Colonel Zakaria will speak to that. Then in dealing with these transgressions at Pharmacy Council, we have committees that looks into the complaints that we receive. We have the Committee of Preliminary Investigations that deal with all the complaints that we receive. It is the first committee where where complaints are looked at. So this committee will look at everything that is received as a complaint and decide as to whether we have merit to proceed with this matter or not. And if they decide or recommend that we cannot proceed with this matter, then that matter will be no further action. But if they decide or recommend that we can go forward with the matter, they will refer the matter to the Committee of Informal Inquiry or to the Committee of Formal Inquiry, depending on the seriousness of the complaint. So even those committees are also regulated in terms of Chapter 5 of the regulations published under the Pharmacy Act. So when I go to my last slide, it will be the curbing of abuse. What do we do as Pharmacy Council? do we sit down and relax and wait for other person to inform us that there is this pharmacy that is, yes.
Can I come in again? Can I ask
Yes.
you to, I think it's a bit difficult to follow without seeing the
Yeah.
slides.
The slides, no? Let me try and share on my
So-
side.
The green button at the bottom of your screen, it's written share screen. It should be between Q&A and the raise hand, just at the bottom of your screen. You should see,
Okay.
yeah, there should be something that says share screen. It's really important information that you're sharing, but it also makes more impact if people can see what you're talking about as well. Are you winning?
Let me ask my colleague, Mr. Mashishi.
Mr. Mashishi, you're already sharing the slide. You were already sharing the slides. It's a question of, yeah, and then moving.
Yeah, I think the slides were moving along with Mr. Nkanyane. He was on the slide, so I thought maybe
Now we
I
are
have
on the
connectivity
slide,
issues or something.
we can resume. Thank you so much. Over to you again, Mr. Nkanyane.
Thank you very much, Spusiso. So I was dealing with the role of counsel in curbing the abuse of this medication. So we don't normally sit down and wait for a complaint to come from the public. We conduct inspections, monitoring inspections. We have inspectors that are provided or given inspection to conduct in various pharmacies. So we have categories of or the gradings that we normally use. You will have your grade A pharmacy. If a pharmacy obtains a grade A, that pharmacy will be inspected in 3 years. If a pharmacy receives a grade B, that pharmacy will skip a year and will be inspected in the other year. A pharmacy that receives a grade C will continuously be monitored or continuously be inspected until it complies with good pharmacy practice. When a pharmacy receives a grade C, maybe for consecutive times or for the second time, we consider for the removal of the pharmacy recording. So we see that this person does not want to comply with good pharmacy practice, and we can no longer have that type of a pharmacy registered with us. And then we have a process or a guideline that guides us for the removal of the recording of the pharmacy. As we know that Pharmacy Council does not issue licenses, therefore we cannot say we are removing a license. Pharmacies are recorded with council, hence we can remove the recording in terms of our act. And then after removing the recording, we will refer that pharmacy to the Department of Health for them to deal with the removal of the license after we have recommended to the DG to say, we have found this pharmacy not compliant with the good pharmacy practice. Therefore, we recommend to you that you consider removing the license of that pharmacy. Again, Pharmacy Council has also or has started to develop a competency or a minimum standard for the misuse and abuse of this medication, and that minimum standard will also be aligned with the good pharmacy practice. Then the last point is that we have collaborative investigations with SAHPRA. We have started this year to do these collaborative investigations in terms of sharing information. So when the investigators from SAHPRA, if they are in the pharmacy and they require information, they don't have to send an email or follow a long procedure to access us. They can just call us. We have our numbers. They can call us so that we can investigate as quick as possible, so that we can achieve our goal in terms of curbing the abuse and the misuse of these products. We have not yet, or we did not include the email address that we use for sending the complaints. We are going to run an awareness hour around July via social media to alert people to say these are the ways to lodge complaints with Pharmacy Council. Thank you, Chair. I think I'll just wait for the last speaker maybe to receive the questions if there are any other questions that which will be directed to us. Thank you very much.
All right. Thank you so much, Mr. Nkanyano, for the overview on the code of conduct and the role of counsel in curbing abuse. I think also to just reiterate, we please continue to field questions on the chat. At the end of after the last speaker, we'll then direct each of those questions to the relevant panelists, and they will be addressed depending on time. And then next on the program, we've got Dr. Estienne. Dr. Estienne is the Professional Development Officer at the Pharmaceutical Society of South Africa. She'll speak to Codain Care, and without wasting more time, over to you, Dr. Estienne.
Thank you very much, Sibusiso, and good morning, everybody. And thank you for the opportunity to participate in this very important discussion on codeine-containing products, and then specifically from the view of the pharmacist and the pharmacy profession. So colleagues, if I can kick us off, obviously, when it comes to codeine-containing medicines, the topics that we've already heard this morning and the sentiments shared talks to the abuse, misuse, and overuse of these products, not only by the youth during this youth month, but in general and overall by patients. So I would like to bring a different side to this as well, that firstly, we've been talking this morning already about the intentional misuse, abuse, and overuse of the medicines. So this is in cases where patients who acquire the medicines through different pharmacy or pharmacy hopping, as we know the term, and that on average a patient can utilize 3 to 4 different pharmacies on a daily basis, whether it's where they could get their chronic medication from, where they quickly stop for acute medicine, or where they'll go for their monthly needs in terms of medication. So a key failing point in this sense is that the current healthcare system is lack of a national sector-wide database or dispensing network. In other words, each pharmacy or pharmacy group has their unique dispensing system, which is not linked to the neighboring pharmacy necessarily. But colleagues, an important factor is also the unintentional abuse and misuse or overuse of medication. And this is where there's the unintentional overdosing by duplication of different types of codeine containing medication. So as we all know, there is a different or a wide range of codeine containing products for different minor ailments, which includes, for instance, colds and flu treatment, sinusitis, cough, minor sport injuries, headaches, or other pain conditions. So it could happen that the patient might visit pharmacy A, which is their regular pharmacy for treatment of colds and flu. And then when they travel, they visit pharmacy B and ask maybe for a cough syrup or something for a headache. And because the pharmacists don't know the previous record of medication, there could be this unintentional overuse of medication. So colleagues, this is then a representation of an industry proposal which have been submitted to SAHPRA as long ago as 2020, just before we hit the pandemic, and on a call from SAHPRA in terms of solutions for this problem. So this is we're proposing a national sector-wide database. So this would inform the pharmacist at the point of dispensing of any potential overuse, misuse, abuse, or duplication of products recently dispensed or currently used by the patient. Without this sight of a complete history of dispensed codeine-containing products, irrespective of the place of purchase or the pharmacy that you visited, it's not possible to pick up these duplications that could lead to overuse, overdosing, and which may result in addiction or subsequent abuse. So this national sector-wide database is referred to as the Codeine Care Initiative, and it aims to protect the patient from harm. So the establishment of this centralized database will facilitate the appropriate action by the persons selling these medicine or scheduled substances with an overuse, misuse, or abuse potential, and to protect the patient from potential duplication of therapy. With this initiative, we aim to institute a monitoring, reporting, and education system that will flag potential misuse, oversupply, and unintended overuse, regardless of the dispensing facility, and this will be based on the use of the identification number, which have been incorporated in Regulation 33 of the General Regulations to the Medicines Act, which was previously a stumbling block for this initiative. And this will be integrated across all dispensing systems, regardless of the service provider use, to include data input along the entire supply chain, something that was mentioned by Ms. Mafudi in her presentation. So changing the reporting at each level. This will also assist the pharmaceutical care task group that could be notified to intervene where risks are suspected. And my colleague from the South African Pharmacy Council has also alluded to this collaboration. It's important to take into consideration that patient information will only be available at the point of dispensing by the pharmacist for the purpose mentioned above. But thereafter, information will be de-identified for any other reports issued. An important point that I would like to stretch at this stage, and that was maybe not included in previous discussions or presentations by my colleagues, is that this initiative must also include other licensed sellers other than community pharmacies. Very important, as they are not currently regulated or included in this collaboration. So my request today is very short. We request SAHPRA to really endorse this initiative. This industry-wide proposal is supported by manufacturers, wholesalers, distributors, dispensing software vendors, and information and communication technology companies, community pharmacies, telecommunication service providers, private hospital pharmacies, associations, societies, and higher education institutes. And I'm happy to report to Ms. Mfafudi that the so-called brands that you've mentioned in your presentation, they're already part of the team and supporting this initiative. So we do have the buy-in and support from the Stakeholders Forum on Codeine Care and Medicines with the potential for overuse, misuse, and abuse. Our legislative frameworks are in order in current existing law, as mentioned in Regulation 33. We request to provide proof of identification at the point of dispensing is very similar to the processes currently in place in banks, airports, or the collection of parcels. And the considerations regarding the breach of copy is in line with the good pharmacy practice requirements regarding confidentiality, minimum standards for patient information and advice, as well as the code of conduct my colleague has referred to. In conclusion, colleagues, once this initiative is endorsed by SAHPRA, the South African Pharmacy Council, as already mentioned in the previous presentation, will publish and enforce the minimum standard for the supply of these medicine items and with the potential for misuse, overuse, and abuse. We also recommend that they include compliance questions in the current inspection questionnaire to allow monitoring of order quantities and dispensing records, and again, across the board in all sectors and pharmacies in the supply chain. And non-adherence must result in disciplinary action. As stakeholders, we commit to create a support and referral framework to assist members of the public who may require assistance to reduce or stop the use of these medicines, including where to find support. We will also commit to the education, training, and CPD for healthcare professionals to help identify and manage patients struggling with addiction. And we will also commit to launch public awareness programs. In addition, after endorsement of this program, we do request SAHPRA To also keep in mind other licensed sellers of medicines, such as dispensing doctors and nurses, who must also be enforced to report order and dispensing data through this mechanism. Thank you very much, colleagues.
All right, thank you so much, Dr. Extian. That's been very insightful and informative. We note your call for a national sector-wide database and also the different actions that you've called upon the different professionals to do. Now we'll have a discussion on law enforcement perspective by Colonel Zakaria Sitwape from the South African Narcotics Enforcement Bureau. Over to you, Colonel.
Oh, thanks. Thank you, Sibusiso. Can someone please load my slides? Yes, next slide, please. I'll start with the background. Codeine is an opiate and a prodrug of morphine used to treat pain, coughing, and diarrhea. It is found naturally in the sap of the opium poppy. It is typically used to treat mild to moderate degrees of pain, but there still exists a strong use of this medicinal product with or without a doctor's prescription in greater dosages or for longer periods than were prescribed. The effects of codeine include euphoria, apathy, drowsiness, relaxation. Next, please. Effects of codeine. As an opiate, codeine runs a high risk of its users developing a tolerance and eventually a dependence on it. Although many people begin using codeine to relieve a legitimate condition, it is frequently abused as tolerance develops. Many codeine users begin to turn to the drug to cope with all of their physical pain and eventually their emotional pain as well. Purple drink. Codeine cough syrup is used to make purple drink. Purple drink is a recreational form of the drug made by mixing prescription-grade codeine cough syrup with soft drinks such as Sprite or Mountain Dew, and sweets such as sour worms and jelly sweets for consumption in large doses. It is also called lean syrup and zizap. Teenagers in particular take codeine cough syrup together with alcohol to get high before going to parties. The identified risk of this addiction is that it becomes a gateway to even more stronger and hard drugs. Next, please. Current status of codeine within South Africa. Within a period of 5 to 6 years ago, codeine use was also seen significantly more as a public health problem in South Africa. And since then, there were no reported cases of drug outlets dealing in or in possession of codeine medicinal products. During that period of time, drug rehab centers were being inundated with children hooked up on the drug. So currently, we don't have any record of cases where medicinal products containing codeine are registered. Even with our forensic science laboratory, we don't have any such cases currently. That is the end of my presentation. Thank you.
All right. Thank you so much. Thank you so much, Colonel. I'll still encourage people. I see there's a lot of activity on the chat, and I'll still encourage people to continue to put in more comments, questions onto the chat. We'll move on to our last speaker for the day. We'll give insights and perspectives from a former user, and that's Mr. Koketo Makubane, who is the Gauteng Community Linkages for South African Network for People with Drugs. And over to you, Koketo.
Good morning to all. I'm Koketo Makubane, the Gauteng Community Linkage Officer for SENPUT, which is the South African Network of People Who Use Drugs. I'll be speaking today based on my experience with illicit drugs and also licit drugs, because previously I've been addicted to both. I'll be touching base on the three topics: support harm reduction related activities, coping with drug dependence, and options for rehabilitation. Harm reduction refers to an approach to services and policy that protects the life and health and dignity of people who use drugs and their community. Unlike approaches that insist that people stop using, harm reduction recognizes that many people are not willing or able to abstain, and that withholding assistance and otherwise punishing people and communities for using drugs only worsens health and racial and economic inequalities and other harms. What are some of the examples of harm reduction? Community management of opioid overdose, whereby previously in 2021, we rolled out a program whereby we rolled out naloxone program, whereby we were training members of the PWD community on how to administer it. And it has already yielded results whereby lives have been saved before. Because sometimes opioid users get arrested, go to prison, and then they come back and their tolerance level is down. And then they go back to using the same amount, the same dose that they used before, and they are at greater risk of overdosing. That's where naloxone comes into the picture. Overdose prevention sites. That's what we advocate for. If overdose prevention sites were there, risk will be minimal because we'll be able to observe everything that happens amongst our PWD community. We are not saying legalize drugs, but we are saying decriminalize drugs for personal consumption. And the third that I'll be talking about speak directly to what we are also talking about, medication-assisted treatment, whereby previously here in the city of Tshwane, there was a program that started, which is called COSUP, which is the Community-Oriented Substance Use Program, whereby it uses a set of principles of harm reduction, whereby you are taken due to what you want as a PWD member. You are given the information on the harms of the drugs that you are taking and how you can manage them. And some of the users get prescribed methadone. Some get prescribed Cybaxone. As we all know, those are Schedule 6 drugs and they are highly regulated. But I've been reading the comments from everyone in the house. They've been saying increased schedule for codeine. You know what? Even if you increase schedule, what you will only be doing is that you will be increasing the market value of the codeine in the black market. The access will continue to be there. What needs to happen is that harm reduction, demand reduction, and supply reduction, we need to all work together as all stakeholders. Law enforcement dealing with the supply side of things, healthcare professional, people who use drugs in harm reduction and demand reduction, people who use drugs, the community working together, speaking of the problems that us as PWDs, because drug use sometimes is not only, it is what you get at face value. There are underlying issues for a person to use the certain substances. If we can be able to deal with those issues, we will definitely win the battle. Also, what's important is for us to have also peer programs whereby people who have used this, whether being illicit or licit drugs like codeine, coming back to educating their peers on the dangers of the codeine and also sharing their story, relating with those that are still in drug use. In that way, they will be playing a positive role in the community. Recovering from a substance use disorder is a complex process that often needs a long-term plan. We have goals for intervention. The first one being awareness. The second one being motivation. We need to be motivated. The third one being an action plan, whereby it becomes very critical as a user to have a plan way forward, because you'll be in a way starting a journey whereby you are just like a toddler. You are just like a little child being born again, because you don't know how it is to live normally, just like everyone else, because you've been addicted to a substance. Maybe you've been dependent on it. Your functionality depended on the substances. Keys to a successful intervention is that you plan ahead, you time it right, you communicate with others, and also you need to accept that you're gonna expect triggers. And when you get those triggers, speak. That's where evidence-based psychosocial interventions are so critical in the implementation of the program, whereby the medical side of things can't work in solidarity alone. It also needs the psychosocial interventions, whereby we have some of the therapies like cognitive behavior therapy, motivational interviewing, relapse prevention, and also we have CACs, which are called community advisory groups, whereby recovery and those that are still using get together. They speak about their current issues. They relate to one another. They share some, he's going through a certain phase in his life that someone has went through and he was able to pass through that. So they're able to share advices and also motivate each other. Psychological treatment is more effective when prescribed with substitute prescribing that when medication or psychological treatment is used alone, particularly for opioid users. The evidence base for psychological treatments need to be expanded and shall include research on optimal combination. As we all know, psychological interventions are essential also for the treatment regimen, for the patient to stick to the treatment plan. That's where, like I've seen also with the OST here, when they were giving heroin users a substitute with methadone, not having psychological programs whereby the methadone alone didn't solve the problem. People were getting addicted more to the methadone, or using the methadone while also still using their substances. Some were selling it. So that's why I say psychological programs, psychosocial therapy, and medical assistant programs go hand in hand. And also, all role players need to get together as all stake players in trying to get the struggle of drug abuse. If we work together, we can be able to yield positive results. Thank you.
Thank you. Thank you so much, Koketo. Thank you so much for those perspectives and also your suggestions in terms of what interventions need to be done to ensure that the misuse of codeine and other related products is capped. Since we've had the last panelists speak, we'll then move on to the questions. The Q&A has got more than 90 questions and comments. I think I'll hand it over to the SAHPRA CEO to take us through asking the first question, and then I'll ask the second question.
Thank you, Sbusiso. I'll ask Daphne, my colleague, a question that's come up, and I see some members have already tried to reflect on it. The first is around the upscheduling of codeine. Daphne, if you can share maybe some of the processes and the thoughts that we've gone through and why we haven't upscheduled. I think some colleagues have already spoken to that. The second question is on the Codeine Care Initiative, this nationwide database. Can you maybe share in terms of SAHPRA's view on that and the engagements that we've had with Marit and the team? Thanks. I'll pause here for now.
Thank you, CEO. And I just want to thank the activities in the chat I was reading. And yeah, I'm a pharmacist as well. I just love the passion that I'm getting from the in terms of how we can best resolve this matter. So in terms of upscheduling, as I thought maybe to mention the word pharmacist would also let you know that my passion in pharmacy is great. And as pharmacists, we need to make sure that the pharmaceutical supply chain as integrity we protect. And we have done lots of engagements in establishing whether rescheduling, upscheduling in particular, will resolve this matter. So through those various engagements, ICPA will also come to this and say they did not, and a lot of pharmacists did not support upscheduling because they believed that at the moment there is greater control from various sectors of pharmacy, and let's do more research and identify where exactly problems are and how best as a collaborative can we resolve this. And then of course Codeine Care Initiative was one of them, was one of the initiatives. But let's be honest, how far is that? Who owns that? And how do we as a collaborative, because somehow the ball has been dropped, colleagues. So I think this is one of the, why it's called Codeine webinar, is because when you are dealing with a wicked problem, you need to ensure that one agenda at a time. So then already there is this platform which can actually even resolve for other problematic substances, as you are mentioning in the chat, but we always need to start somewhere. So let's revive that Codeine Care together and see how we can then bring a solution to the substances that are problematic, because we know it's not only codeine, but this is the start of how can we broader resolve these challenges. So Mariette, we will get engaged. I know Mr. Beva, who's also in this platform, he's the one that we were working quite a lot with from a while back, and some of the colleagues. So, but definitely from SAHPRA's side, we will be engaging with the profession on this matter. And I'm so excited with the comments on the chat. Thanks you.
Thank you. Maybe Marit, you can then come in. I mean, I think what you're proposing certainly and I can see even from the comments is what would be welcome. How would you go about really having such a database that collects all this information from all the various stakeholders? And another question that came through is around compliance with POPI. So if you could just reflect on that, thank you. Then after that, Sbusiso will follow up with the next set of questions.
Thank you very much, CEO, and thank you, colleagues, for the vivid discussion that we have. And thank you also for our colleagues that have commented in the chat, and we can see clearly the trend that's coming through. So, CEO, to your question, the Codeine Care initiative is really nothing new. It's been in place. The hiccups that we had was twofold. Number one, at that stage, prior to the current general regulations published in 2017, it was not a requirement for a prescription to have an identification number. So whether that prescription is coming from an authorized prescriber or it's generated by a pharmacist through pharmacist-initiated therapy or a pharmacist prescription. That has been resolved with the publication of the general regulations in 2017. The only other issue that is remaining is that this initiative is not enforced. So back when it was initiated around 2013-14, it was a voluntary participation. Now, we won't be able to curb this problem if it's not an all-inclusive, mandated, industry-wide participation in this product and in this program. So in essence, to talk to the current program that was running and was available, it was implemented throughout the different dispensing programs, so that's already been taken care of. What we do advocate for is to broaden this program, to include it from the point of either manufacturing or importing, and to be able to support SAHPRA in this way of ensuring that those numbers are kept up and adding up as they move through the supply chain. An important aspect that also has to be included, and for that we do need SAHPRA's endorsement, is other dispensing professionals outside of the pharmacy profession. They must be able to be part of this program and to document their numbers in terms of orders and in terms of dispensing or issuing to patients. Dr. Sir, if I can then add to or elaborate on the aspect of POPI. So just keep in mind that in terms of a pharmacy, in terms of the dispensing program, the patient's information is handled confidential. That is already a requirement in the good pharmacy practice. It's already a standard practice in any pharmacy, and I believe the same in our dispensing colleagues as well. So there's a elaborative minimum standard on how to manage this in terms of the pharmacy profession and in terms of dispensing to patients. What this program will add is that in the case where you dispense, for our colleagues that have maybe not been working with this program before, is the moment you dispense a product in your dispensing platform that contain codeine, a message will pop up to say a similar product has been captured or purchased 2 days ago, for instance. So it will not state the type of product, it will not state from which pharmacy, it will simply be a message, a warning message that will come up. Obviously, the patient's information in terms of that database will be de-identified. So a patient will have a unique number, as with any other data set. It will just then pick up that this unique identifier has purchased a medication before. So to come back to the minimum standards in terms of patient information and advice, the minimum standards of record keeping, and then very importantly, our code of conduct that elaboratively talk about confidentiality. I cannot see that this is a problem other than the general practice of a pharmacist in taking responsibility for a patient's medication needs and ensuring appropriate and sufficient medication use by patients. This is nothing else than what we do on every single day when facing with patients and advise them on appropriate medicine use.
Thank you, Mariette. And I'll move into the next questions, which are more on the law enforcement side. I mean, there is a comment that speaks to how these products are now trading as currency. and if the Hawks are aware of it. So Colonel, this question is for you. And also someone, I think it's Shannon, has asked or has said they would like to know how SAPS is assisting the local community pharmacists in terms of illegal scripts, stolen script pads. Okay, those are related questions in terms of law enforcement, but I don't know if Colonel have any take on this.
So, as you will understand, I'm sitting at SANEP, which falls under the Directorate for Priority Crime Investigations, popularly known as the Hawks. So most of these activities where especially our youth are misusing these codeine containing medicine products, those activities are taking place, you know, at the lowest level of the criminal value chain. So we as the Hawks, that does not fall within our mandate. We rely on the mother body, the South African Police Services, especially social crime prevention, of visible policing, and general detectives. Those are the people who are mostly dealing with those cases. We only come in on issues of transnational organized crime. So we have not yet reached that level as a country. But I know that from time to time, members of the SAPS, they do conduct operations with SAPRA, for example. When information is made available, they do conduct some disruptive operations. But from the Hawk side, no, that is not within our mandate. Thank you.
All right, maybe before Dr. Boitumelo comes back, I think I'll take one question on the Codeine K database and the request as made by Dr. Mariette. I think I'll post this question to Daphne in terms of how far we are, if SAPRA is doing anything at all on the database.
The question on the database should be for Marit Sbusiso.
Oh, okay, right. So Mariette, in terms of the database, then it's itself, how should it work and how far do you think things are?
Sibusiso, thank you very much. As I've mentioned in my previous comment, so the database is developed. It was implemented some years ago. It was voluntary participation. How the database works is the program links with all the different dispensing programs in community pharmacies or then hospital pharmacies. And the moment you use the patient's ID number as the unique identifier at that stage of dispensing, as required in Regulation 33 of the General Regulation, so you must enter patient's ID number from the prescription to the dispensing record system. And the moment you will type in or starts dispensing a codeine-containing medicine item as to the topic of today, this software program will then flag up, because it will run through all pharmacies, it will run through all systems to say that this patient with this ID number has received medication containing codeine from a different facility 1 or 2 or 5 days earlier. So we don't know what product it was. We don't know for what condition it was. As I've mentioned, it could be that the patient has received something for cold and flu at their pharmacy 2 days ago. Today they are traveling to Bloemfontein and they feel they develop a cough in the meantime. So they will then also go to a local pharmacy over there and say, listen, I just need something for cough. But the pharmacist won't be able to say, okay, but what else are you using? And the patient might add, oh, not just something for flu, but they won't be familiar with the brand name or the content. So this software program will simply risk, I will simply highlight to the dispensing pharmacist that there is a potential, whether this potential is intended or unintended. And it will enable the pharmacist at that point in time to say, listen, I see on the system that you received a codeine containing product a few days ago. And this might also trigger the patient then to say, oh yes, now that you mention it, I am using a different cough syrup, but I don't have it with me today, for instance. And then this data will then, as I said, after the point of dispensing, it will be de-identified. So there's no way to see that Marit is using this and this product. It will assist us in picking up trends. It will assist us in where there's volumes of codeine containing products going missing, especially if the whole supply chain is involved from the point of this manufacturing through the distribution and wholesale system to the point where the product is dispensed to a patient. And that is also adding up that we will not be able to curb this problem if this is not an industry-wide or sector-wide approach. And that is why we specifically are calling that other dispensing colleagues, other than in the pharmacy industry, should also be mandated to be part of this program. So the program has been voluntary implemented before. There was no hiccups, except that the ID number on prescriptions was not compulsory at that stage. And then secondly, that was not mandated or compulsory for pharmacies or dispensing colleagues to participate. And that is what we are calling for, is for SAHPRA to endorse this program, and that we all as role players in this sector can take hands. Because I cannot imagine that one single role player is to blame for all of this. Thank you.
Right. Thank you, Dr. Mariette. I don't know, Baitumel, if you want to come in.
No, thank you. I've got questions for our colleague at the Pharmacy Council. There's been a number of questions around, there's one question around the pharmaceutical crime task group. How is that working? Is it effective? And what role is it playing in the management of codeine containing products? But also, how are you handling it in the context where it's being made available through online pharmacies? If you can maybe reflect on that. Thank you.
Thank you very much, colleagues. First question, the pharmaceutical task team group, it is formed by Jaco Peterson from Clicks. I think he's a forensic investigator. We are having the meeting, we have meetings every month. So the next meeting will be held at South African Pharmacy Council. If I may check for you, I think it will be on the 1st of July. Yes, it will be on the 1st of July. We are part, but in most cases at that group, what is more, it is presented, it is the track hijacking of these products and the smuggling of this product out of the country. There are various participants in that group from your ASPEN, the law enforcement and the Interpol. So even ourselves, we are there, and other manufacturers of medication, they do participate. So if colleagues are interested in terms of joining the group, Daphne has my email address. You can share your email addresses so that I will inform Jaco to invite you to participate in the group. Thank you very much. The second question, what was the question?
Do you want me to repeat it? It's the one
Yes, yes,
online.
Oh, the online website pharmacies. You'll note that Pharmacy Council has a minimum standard for internet site pharmacies. So the main pharmacy, which is a premises, must be linked to the website pharmacy, if that is the legitimate pharmacy which is online. But we do receive complaints, like today we did receive a complaint that there is a pharmacy called DB Pharmaceuticals they are advertising online. We have received so many numerous complaints around Duromine, but you'll find that those internet sites are not even linked to any premises which is registered with Pharmacy Council. We do refer those type of complaints to SAPRA and the advertising code. There is an advertising code. Is it advertising code of conduct or something like that? But we do have, I think is Bunet. She's the chairperson there. So we do refer those complaints to them so that they can look on whether the manner in which they are advertising. But in most cases, when the advertising relates to medication, we do refer that to SAPRA. Thank you very much.
Thank you so much. I see we only have 9 minutes left. You know, our speakers have been looking also at the questions. I'm going to ask that we start wrapping up. If each of the speakers will go in the order that you spoke in, can give concluding remarks. But in your concluding remarks, if you could just share what are the way forwards for the specific institutions that you represent. Let's start with, I think it will be Daphne first.
Thank you, CEO. Thank you very much for such a brilliant attendance for this webinar, because from that one has identified that we need to strengthen our collaboration. So at SAPRA, we do have internal expert committees that we consult with regards to such matters. And what we will do as well, we do also have got various stakeholder collaboration, external stakeholder collaboration that we engage in. And we will definitely use this as because we have already started. This was one step further to say, how do we then strengthen listening to the whole chain on this Youth Month to ensure that when we go forward, at least we know that we will go forward on a note that we are developing further into where we are. So with the Codain Care and also the colleagues that are here, we will take note of all the comments that have been made, and then we will engage with yourselves just to move forward to say how best can we move further, looking at curbing this problem together with other substances that are abused. Thank you.
Thank you very much, Daphne. I'll then ask Mr. Kanyani from the Pharmacy Council.
Thank you very much. I think from Pharmacy Council, the word is we must collaborate. It's to collaborate as stakeholders, because if we collaborate, I think we'll achieve our objectives. We have a good working relationship with SAPRA. I think from our side, we are lagging in terms of the law enforcement, in terms of the police services. We tried to establish some sort of a relationship, but we don't get the necessary assistance that we require when we do our own investigations, because we don't necessarily receive complaints from registered premises. There are certain premises which are not registered, but if we have that collaborative investigation with the police, I think we can root out this problem of abuse, because we do have Section 29 of the Pharmacy Act that allows us to open a criminal case for people who are not pharmacists or for premises which are not pharmacists, so that we can root out the codeine abuse by our young children, and it affects our communities, because if you have never come across with a person who's addicted, you'll never understand. But if you have come across with one who is a problem or who's related to you, you'll understand that this is a big problem. Thank you very much.
Thank you so much. I'm then going to ask Dr. Extian, Marit Extian, to comment.
Thank you very much, CEO. In closing remarks, I just would like to highlight that I do represent the PSSA today, South Africa, Pharmaceutical Society of South Africa, but in essence, we are a member of the Stakeholders Forum for Codeine Care Medicines with the potential of misuse, overuse, and abuse. And this is a sector-wide, industry-wide stakeholders group who are committed to realize this and for the betterment of the patient out there. So PSSA, together with our colleagues at the Independent Community Pharmacy Association, ICPA, act as the secretariat to this group due to our non-commercial interest in this. And we would like to see this realized as the many promises that were made. But colleagues, if I can add tongue to cheek, let's not wait until Christmas to meet up and to take this discussion forward. Thank you, colleagues.
Thank you so much. And then I'm going to ask Colonel Sitwape to comment.
Oh, thank you. Yes, I've taken note of the concern by Mr. Nkanyani. I will gladly like to share his contacts so that I can assist him, so that in future when they want to be assisted by the police, then I will actually direct him to the right people who will assist him, not only to him, but everyone who was participating here. And another thing, I just want to make a comment, especially I heard one of the speakers, touching on the issue of awareness. So I was of the opinion that for now, when it comes to awareness, we should restrict it only within the supply chain. Because, history has taught us that the moment we reach out to the greater community, it will be like we are actually promoting this whole thing, even to our youth who are not aware of this codeine. Because according to studies in the US, after these awareness campaigns were conducted, at a certain point in time, it was recorded that 33 million citizens were addicted to codeine in 1 year. So we need to be very careful. Let's for now restrict this awareness within, the pharmaceutical industry. That was my humble submission. Thank you.
Thank you so much. And certainly not least, but our last speaker, Mr. Koketso, please, if you can give some closing remarks.
From my side, I don't have much to say, but like the other speaker has stated, I believe through collaboration amongst all stakeholders, we can achieve the desired results. I believe if we work together as a team, we can do more in achieving the goals that we want, in achieving getting our country, our youth off codeine. Thank you.
No, thank you so much. Colleagues, thank you so much for joining us this morning. Very important discussion, but you can see that all of the stakeholders represented here are quite intentional about ensuring that whatever they need to do within their respective mandate, but also collaborating with each other, that it gets done. A comment that was made on the chat, that can this not be a talk shop? And it certainly is not. I mean, this is a culmination of a lot of work that has gone on in the background and more work that will continue to take place. So thank you so much for availing yourselves for this discussion, and thank you for the input and all the comments that were shared with ourselves. Sibusiso, I'll hand over to you to close. Thank you.
Thank you so much, Dr. Waitemelo. And I think from my side is just to thank all the participants, thank all the panelists for the wonderful discussion. And as you have rightly said and said in the chat, may it not be just a talk show, may all do all that we can to ensure that our youth and our people are safe. With that being said, have a wonderful day. Thank you.
Thank you.
Thank you.
you.